liver patients and their families. The mission is to facilitate, advocate, and promote education, support, and research for the prevention, treatment, and cure of liver disease. This webinar is part of ALF's ongoing efforts to increase awareness of critical liver health issues like NAFLD. In fact, it's worth noting it is estimated that as many as 90 million or more Americans have NAFLD. The American Liver Foundation is committed to being in the forefront of this emerging epidemic and to being a resource for physicians as well as patients. Later in the program, we will share a bit more about some of our programs. We are pleased today to present today's webinar, and we thank our special guests and leading experts from Emory University School of Medicine for taking the time to speak about this vitally important topic. Our first speaker is Michael Voss. Michael Voss is an associate professor of pediatrics at Emory University School of Medicine and a physician on staff at Children's Healthcare of Atlanta. She specializes in the treatment of gastrointestinal disease in children, as well as fatty liver disease and obesity. Our second speaker today is Dr. Saul Karpin. Dr. Saul Karpin is a professor of pediatrics, Raymond F. Shinazi Distinguished Biomedical Chair, Chief of the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at Emory University School of Medicine, Children's Healthcare of Atlanta. We'll now turn the program over to Dr. Voss, our first speaker.
Great. Thank you, Tom. And it's really a pleasure to do this today. And thank you to the American Liver Foundation for organizing this. So let me advance here. Let's see. Jonathan, I need to be able to advance the slide.
You should have control. There you go.
Got it. Okay. So now that I have control, so we'll just take a moment to look at my disclosures. And there you can see, and we'll go on to the first slide. So I think one of the striking things is how early the obesity epidemic starts. And this is data from the Centers of Disease Control and Prevention looking at obesity in preschoolers. And you can see that this affects almost every state across the nation. And just the only ones where we don't have data are just those two that you see. But if you look at the dark blue squares, those are counties that have greater than 20% obesity in their preschoolers. And this is striking because if a child is already obese by the time they're in preschool, the future is really concerning given how difficult it is to reverse obesity. The NAFLD epidemic is not just something that affects the United States. And in fact, as the data has become more available, we see that it affects regions across the world. This is prevalence data that was published in 2015, and it shows that the prevalence in children of NAFLD is it's really the same across the world. So you can see North America, 6.5%, Europe, 5.7%, Asia, 5.9%, Australia, 10%, Africa, 6.8%. The South American data there, they had fewer studies, and so I think it's a little bit skewed. So it's probably similar to the other regions. But what's so striking is the number of children this represents across the world. So one of the questions I often get asked is NAFLD increasing, or is it just that people are looking for it more? And so we did this study a few years back to examine that question. And so what we did is we applied the same criteria to nationally representative data, the NHANES data set, in the 1988 to 94 data set and compared that to the 2007 and 2010 data set. And you can see here that what we've been able to demonstrate is that the NAFLD prevalence has almost tripled in the United States. So this isn't just that we're more aware, we have physicians looking for it more. This is an increase in the incidence and prevalence of the disease. So how important is this? So 5 or 6% in a region, what does that mean? Well, I think it helps to put it in perspective if you compare NAFLD to the other liver diseases that we're all very familiar with. And so you see here a list of percentages, and this is adult data, but it helps to give us an idea of the comparison, and it's probably similar in pediatrics. So NAFLD at the top is 5 to 20% of the population, depending on which group you're looking at. Hepatitis C, which is an important liver disease with a lot of morbidity, but is really a much smaller percent, so 1.3 to 2%. Alcoholic liver disease, 1%, hepatitis B, 0.3 to 0.4%, and then the other liver diseases, autoimmune hepatitis, primary sclerosing cholangitis, primary biliary cholangitis, alpha-1 antitrypsin. You can see they're so small we don't have percentages. It's just a few cases per 100,000. Not saying that these are not important diseases, but it helps to understand the relative scale of the problem of NAFLD. Adult NAFLD has also increased in prevalence. This is another study very similar to the one that we had done in pediatrics. This was before ours. This is by Dr. Yanasi et al. And they also looked at adult prevalence of NAFLD, and you can see that it more than doubled over that same time period. So what is the range of disease in kids? I mean, do they all have very minor disease, mild? No, so they have the full range of disease that we see in the adult population. And just to remind you of that, so on the left-hand side, you can see this is a slide showing steatosis, primarily steatosis. And you can see how the lipid has displaced the components of the cells. And this liver looks like it's almost entirely fat. So that's simple steatosis. Here in the middle is a picture of NASH. So this is steatosis plus inflammation. See the blue inflammation here in the portal area. So, and again here, and then scattered a bit throughout the parenchyma. And then, so that's called NASH, which is non-alcoholic steatohepatitis, abbreviated NASH. And the three criteria of that is inflammation, steatosis, and hepatocyte ballooning, but NASH often leads to fibrosis. And a fibrotic liver is the end stage or the result of NASH for years. So here's a picture of cirrhosis with bridging fibrosis and NASH still present. When the liver gets to be very end stage, the NASH may not be present anymore, and they may have just scar tissue. So are there differences between adults and children? There are. So it's interesting. It's actually looks like it might be a more severe condition in childhood compared to adults, and this is kind of overall looking at the population. So in adults, the proportion with NASH is really the minority. So more have steatosis and have milder disease. But in children, although this varies by cohort, the proportion with NASH is typically the majority of those being diagnosed, so more common to have severe disease. On the right-hand side here are some differences in the histology between adults and children. So adult type NAFLD tends to be more in the zone 3 or the central vein areas, so that's where the steatosis is located. The ballooning, hepatocyte ballooning is more common, lobular inflammation, and pericellular fibrosis. So the fibrosis is kind of all through the parenchyma. As compared to pediatrics, shown here on the right-hand side, in children, we often see a pattern where the inflammation and the steatosis is centered on zone 1 or the portal area. There's rarely the hepatocyte ballooning or the dying cells that we see in adults. And the inflammation is more likely to be portal and periportal fibrosis. And so this has been termed the pediatric pattern of NASH or NAFLD. And the other interesting thing about this is that children can have this pediatric pattern, or they can have the adult pattern. And in fact, by late adolescence, most children have the adult pattern. So what happens to kids who have NAFLD? So let's talk a little bit about the current understanding of the natural history of pediatric NAFLD. And just a few caveats before we talk about the natural history. We have very little long-term data in children currently. The best studies that we have are crossing only 2 years in a large cohort. Very few children have repeat liver biopsies, so we don't have a good way to provide data on the longitudinal history of the liver biopsy-based findings. And then there's very few outcome events. I mean, very few children go to end-stage liver disease while they're still in the pediatric time period. They may go to end-stage liver disease and need a transplant in their 20s or in their 30s, but that's not going to show up in the pediatric databases with the current systems. Children with liver biopsies may be the tip of the iceberg, the more severe cases, and may not be representative of this entire spectrum of NAFLD that we see in children. So with that in mind, I'd like to show you a bit of data that I find very concerning. So one is, how fast does fibrosis progress in children? And like I said, we don't have good long-term studies in large groups of children, but this is a case, a representative case that's published by Cincinnati group. And you can see at age 11, this child had stage 1C fibrosis. At age 16, stage 3 fibrosis. And this is completely asymptomatic. So if these liver biopsies hadn't been done, no one would know that this rapid progression of fibrosis was occurring. Stage 3 is, second to last. So 4 is cirrhosis. So in the adult data, the progression of fibrosis in NAFLD is estimated to be about 9 years per stage. So give this child 9 or 18 more years, put them in their mid-30s, and they'd probably be ready or needing a liver transplant. On the right-hand side here, this is data about what happens when a young adult reaches end-stage liver disease and has to have a liver transplant. So this was published by Naeem Al-Khoury in 2017. And they looked at the UNOS data of young adults aged 18 to 40 who have been transplanted for non-alcoholic steatohepatitis. And they found that 330 patients had been transplanted who are under the age of 40 for this indication. And they looked at follow-up data after 4 years to see what happens after having a transplant for NASH as a young adult. And it's grim. So 100 of those 330 had died by 4 years, 30%. 11% were retransplanted, and of the 230 that lived. So basically 41% had a difficult, if not a fatal outcome after being transplanted for NASH. And so what I take from this is that this is not only an epidemic, but it's extremely worrisome and something that has to be treated during the childhood time period and the very early adult time period, because waiting for these folks, these kids, to progress to end-stage liver disease and get transplanted is clearly not the solution. So what else? I mean, so we know that they can go on to end-stage liver disease, but the other thing that's really important about NAFLD and NASH is that it causes and is associated with many other comorbidities. And here's the steatosis again, and the steatosis in the liver is strongly associated with an inflamed visceral fat mass, as well as the progression to type 2 diabetes and progression to strokes and heart attacks. So we can't just think about the liver when thinking about fatty liver disease. So putting this together, do we have enough knowledge to say something about the long-term natural history? And this, we really don't have longitudinal data, but looking at the cross-sectional data points that we have, you can put together a timeline of the cardiometabolic disease, and that's what I've done here. So we know that maternal factors play a role, so there's an importance in that phase. And then infants are born with fatty liver, and we don't really have data. We have data on infants. We don't really have data what happens between in the liver. So this is like the 5-year-old, 5 to 7-year-old. We know that insulin resistance is common in that age, as well as hypertriglyceridemia, but the liver is hard to evaluate, and few liver biopsies are done in that age group. So by the time they reach 8 to 12, they frequently present with NASH, and that's found by liver biopsy. Once NASH is in place, there's a 5-fold increase in risk of developing type 2 diabetes in the late adolescent years or 20s. And then you've heard already me talk about the progression then to cirrhosis, hepatocellular carcinoma, and possible need of transplant. And then this cardiovascular disease association is extremely important because NASH in the teen years probably is going to result in a greatly increased strokes and heart attacks in the early adulthood based on what we know from adults, so extrapolating back from that data. So we need to identify the kids with NASH, and we need to do that so that we can stop their progression to type 2 diabetes and hepatocellular carcinoma and cirrhosis, but also so we can stop their progression to cardiovascular disease. So it really needs to be a very holistic prevention and treatment plan for children. So just a quick couple points on what causes NAFLD, like why do we have this big increase? Well, it certainly is genetic, which doesn't explain the increase, but it's genetic plus environmental. And this study, I'll just highlight because it was, I think, a very important example of that. And they looked at these 3 different genes, PNPLA3, GCKR, TM6SF2, all involved and associated with NAFLD. And here I'm showing the data on the PNPLA3 gene, but look at here. So across the x-axis, you can see the BMI. So less than 25, 25 to 30, 30 to 35, and then greater than 35. And if they had both, so a homozygous MM, or the affected polymorphism, then they have a highly increased risk of having fat in the liver. This is hepatic triglyceride. So here, almost 15% if you're homozygous and significantly overweight, as opposed to if you're heterozygous or don't have the gene. So having an elevated BMI without the gene did not trigger the increased hepatic fat. And so what this tells us is that it's genetic overlaid with the presence of obesity. So then the question that I come with next is, well, how did they get obese? And that leads us to our next point, which is there has been a dramatic change in the U.S. diet in over the last decades. And actually, this problem goes way back. And I'm going to focus on sugar for just a few minutes. And this is not to say that there aren't many other changes, like a reduction in activity or other dietary changes, but sugar is one that has dramatically changed, and we know is strongly associated with NAFLD for some reasons, which I'm going to show you. So this figure here is showing us free sugars. So the red is just juice and other fruit-based sugars. The green is the blue is added sugars that are added to food or drinks. And so just kind of the typical cane sugar or high fructose corn syrup. And this is consumption in children. So if you look across the bottom, so this is age. So from age 1 on, children are consuming in the US way higher, much higher amounts of sugar than they should be. So the red line is the recommended amount, 25 grams a day. No kid even gets close to this. And so I think this is a huge opportunity, but it's likely also a big driver of the severity and possibly the onset of NAFLD. And that's because of a couple important things. And one is because the liver is central in lipid regulation and probably takes the bigger hit from this high sugar diet. And so here's a figure. This is a cartoon depicting very simply this cycle of lipid regulation. So lipids come into the liver. Carbohydrates here are a big driver of de novo lipogenesis. Beta oxidation, step number 2, is supposed to occur in the liver to burn up that fat, but in the setting of hypercaloric diets, then that won't all get burned. So step 3, the de novo lipogenesis, and then step 4, the export of fat out of the liver. So if step 4 is overwhelmed, then we end up with steatosis, or increased fat in the liver. And de novo lipogenesis is an important reason why sugar increases fat in the liver. And I'll show you that in this next slide. So this was a seminal paper done by Elizabeth Park's group several years ago. And she demonstrated that of all the areas of fat metabolism, it's de novo lipogenesis that is the most altered in people with NAFLD. So here on the right is high liver fat, or NAFLD, on the left, low liver fat. And this gray bar right here is the difference in de novo lipogenesis, or synthesis of fat in the liver. And synthesis of fat comes from, the fuel for that is sugar and any glucose molecules. And so this is, de novo lipogenesis is already defective in patients with NAFLD, and then sugar drives it further. On the right-hand side here is a figure from Sam Klein's group, and they demonstrated that when a patient is driven through an experimental protocol to gain weight rapidly, not only does de novo lipogenesis go up, but beta oxidation also decreases. So this is kind of a double hit, because they burn less fat and they synthesize more fat. So clearly weight gain as well as a high sugar diet are detrimental. So let's talk about the patient for a minute. So what do kids with NAFLD look like? You know, they look like the average kid. They're not that overweight. They're usually mildly overweight. They may have, like when they go to the pediatrician, they may have a little bit of hepatomegaly, but they don't look different. Their labs are different. They often have dyslipidemia, and they have elevated ALT and AST, although many children with just fat in the liver, not inflammation, may have normal lab values as well. The most commonly obtained imaging test currently is ultrasound, and it will look pretty normal, except for it may be bright or echogenic, which can be fat in the liver. So can we just look at a kid like this and say, oh, this is probably NAFLD? Well, unfortunately, no, because this could be Wilson disease. And Wilson disease is a copper metabolism problem that also results in steatosis or hepatic steatosis. And so if this child doesn't have a proper workup or diagnostic assessment, then they could be easily misdiagnosed. And Wilson is much less common, but it's very important because the treatment for Wilson's disease is completely different than NAFLD, and could lead to poor outcomes for that child. So how do we do this diagnosis of NAFLD? Well, I'm not going to go through this algorithm step by step, but this is published in the NAFLD guidelines in 2017 by NASPGHAN and endorsed by the American Academy of Pediatrics. And this shows an algorithm helping to walk through how to determine which children need further workup when their ALTs are mildly elevated. Dramatically elevated ALT always needs evaluation. And then anybody who has red flags for advanced liver disease clearly would need further evaluation. So the typical pathway to diagnosis of NAFLD is to do a clinical exclusion of medications that could cause liver problems, alcohol. We really don't see alcohol problems in children causing fatty liver disease, but that's an important exclusion in adults. serologic exclusion of other chronic liver diseases like Wilson that we just talked about, and then confirmation of the presence of fat in the liver. And ultrasound has been used a lot in the past, but we're quickly moving to MRI and MR spectroscopy-based methods because they are much more accurate and they're much less invasive, clearly. Liver biopsy is the gold standard and still what we have to use, but we're hoping that we'll have better diagnostic tests that are less invasive soon. So, and here on the right is just a picture of a liver biopsy. So a lot of times scores are used in the adult literature, in the adult practice to try to identify those children with more severe NAFLD. And we looked at some of those scores like the APRI, the FIB4, and then a pediatric score, PNFI. Unfortunately, none of them perform even reasonably well. And so these scores are not helpful in pediatric practice. So MRI, I told you, is coming along. This is becoming more clinically available in many centers. This on the left is PDFF by MRI, and you can see that its prediction of the different grades of steatosis in the liver are very accurate. On the right is a volumetric liver fat fraction, also very accurate. So just one note about the future. So we've been working on trying to identify metabolites that would be better diagnostics. And so I'm showing you this heat map because I think it is very striking how different the metabolite patterns are in children with NAFLD compared to the light blue area on the bottom here. And those are children who are ethnicity matched, as well as weight matched, so also overweight. And you can see their metabolite pattern is strikingly different than the children with NAFLD. And so while we don't have anything yet, I do think that this field is progressing rapidly, so we should have non-invasive or blood-based diagnostic tools, hopefully within the next couple of years. So I'm going to stop there, and Dr. Saul Karpin is going to take over.
Thank you, Dr. Voss, and it's my pleasure now to turn the program over to Dr. Karpin.
All right, well, thank you. And I really appreciate, again, I thank the ALF as well. What Dr. Voss just provided was clear, informative, quite actually masterful, and really, at least in my mind, quite sobering for us and for the communities. My role for the second and last part of the panelist aspect of this is to try to provide a therapeutic landscape in children. It could certainly be, if we wanted to talk about randomized controlled phase 3 trials of FDA-approved drugs, this would be an incredibly short talk. But the reason why we're here is that we know that this is coming and that we don't want to have children left out. And perhaps there are some therapies that we could target. I want to first start with some disclosures. I'm a consultant for these three companies, one of which does provide a drug that is being tested now for NASH, and I'll mention that. That's from Intercept. But I also think it's worthwhile knowing that I'm part of trying to fix liver diseases, and that's with the help of NIH, and that's with several really important consortia, one of which involves cholestatic diseases in children, which is abbreviated children, but the other is really specifically related to this topic, and that's with the NASH Clinical Research Network, the last thing shown here, where there is an equal partner of pediatrics to the adult side. And so this is something where we're hoping to advance the field. So I wanted to let you know that this certainly seems to be a new problem, or one where there's a gasp in the room at times where we think that it's new. And I want to start on the left-hand side of this with a slide I made from something that some people don't know anymore, meaning the fellows. These are magazines, and that there's a magazine cover, and this is Time. And I like this for a couple reasons. One, the title is one that I'm jealous that I wish I came across it, but called Girth of a Nation. And if you look at this title, you'd say, oh, this is something that's happened recently. But all you have to do is look at the top left corner. And if you know a small bit of history, think in mind of, it's hard to do this on a webinar, but think what year this was. So this magazine cover came out in 1995. So this is a 25-year problem known to us, the community. And what I like here is this is on the right-hand side is a graph that came out of a paper that was just published last week from the group at Mayo, where they really have a nice mechanism to track their people in Olmsted County. And over time, this is one of the places, and actually is the place that has defined NAFL and NASH in the early 80s. And so taking the expertise of Mayo, but also the ability to track people in their group, they now are able to track how much NAFLD is in their community over time. And this is, if I would point out on the x-axis, starting from 1997 to 2013, and the three different colored bars is the incidence of NAFL that they have in their community based on age of their particular subjects. And in the two bars up here, the blue and the red, you can see, okay, in adults it's rising, all right. But what I don't think people are recognizing, this follows Dr. Voss's introduction, is this is young adults. And so Miriam was talking about this time before age 18, but if you look at this from 1997 up to 2013, there's almost a tripling and more of the incidence of NAFLD in young adults, and this is not horizontal yet. This is really still rising. And so although we do talk about children, and we're not talking specifically about changing liver disease in the child on the day that we see her, but we're actually talking about preparing a generation for normal health and hopefully a normal lifespan. And this is, I think, the most sobering aspect of it. This is also not regional. So people point out we're here talking from Atlanta. This is 100% nationwide, as Miriam has pointed out. So I'm going to just talk briefly and focus on why I'm talking about therapies. And the reason is not just the increased prevalence, and Dr. Voss talked about the increased mortality. And the mortality is really not just liver disease, but it's the diabetes and cirrhosis. But here is a nice survival curve that you don't need to have progression of NASH to have disease. You really just need to have fat. And that's the issue. And then we have kids who primarily have fat in their liver. And the problem is this part right up here, where we have absolutely ineffective therapies. We can certainly talk about the therapies that every person knows about, which is to eat better and to exercise more and to have less screen time. And were this easy or effective or easily applicable to each person, then we wouldn't be having this webinar at all. But we do know that our approaches are absolutely ineffective, and it really is a mechanism that it's not social, it really is pharmacologic. And so that's where I'll be focusing this bit here. And there's a recent review exactly on what I'm talking about pharmacotherapy for NASH that came out in the Journal of Hepatology. And I am not going to go over every aspect of this slide, but what I want to point out is that there are many different agents that are trying to intervene in multiple aspects of it. What Dr. Voss talked about was increased lipogenesis, which I'm circling here. So, well, are there agents that we can maybe stop that Denovo lipogenesis, the DNL that we mentioned? Well, maybe it's really, we know that it's associated with more fibrosis, is associated with worse outcomes. Maybe we should just be attacking the fibrosis aspect of it, and there are agents there. There are other cells that come into the liver as well that participate in this. And so immune regulation is a key. And then there's the ones that I think that we have more enthusiasm for, but also at times more caution, because we were trying to adapt. Well, it's okay to have fat, but it's not okay to have the consequences of the fat. And perhaps we should attack the way that the liver and the body works on the metabolism of either the fat cells or the use of them, and to convert this into something more useful. But what I'm going to talk a little bit more about is something that we've worked on in both in the lab and clinically, is that the way that the liver and the intestines and the bugs in the intestines, the microbiome, all deliver their products right to the liver for the liver to handle. And it's possible that as we change that metabolic potential, we may be able to change the installation and then progression of NAFLD and NASH. And so I'll talk a little bit more about roles for bile acids, although I won't go into stark detail. There are two diametrically opposed ways that people are approaching the bile acid axis, and one is to activate a certain molecule called FXR, which is the nuclear receptor for bile acids. And then there's one where we absolutely block the absorption of bile acids and then reduce FXR agonism. That also seems to work. So we're trying to figure out how can that possibly be, and then also, is this really a nice approach to therapies? So to talk about therapies, there have been many people in this space, and it's really a fantastic field. If one looks at this from a pharmacologic standpoint, Tom talked about the 80 to 90 million Americans. It's really at least that in this country, and the worldwide prevalence is at least in the 20% range across the world. So this is an untapped marketplace, for lack of a better word, that really needs to be approached. And so some people are doing it. And what I'm going to show you here is a very nice slide talking about 3 different outcomes of improvement in steatosis on the left, resolution of NASH, and then improvements in fibrosis. And this is a distillation of those in drug are on the excuse me, the light blue, and those that have been given placebo-controlled trials are in the dark blue, and that these are percentages of kind of improvements. So you want to be higher on this. You don't want to be lower. So there are, and I'll highlight the ones that are in red that are statistically significant, improvements with vitamin E, pioglitazone, and an FXR agonist called obeticholic acid for steatosis. But also you want to resolve your NASH. Well, vitamin E did that, pioglitazone did that, and as did this combined PPAR alpha delta agonist called elafibranor, that too dramatically resolved patients' NASH. But also, did it change fibrosis? And here again, it's not necessarily across the board, and some of it are with different drugs, but you can improve fibrosis. The FXR agonist improved fibrosis, as did a direct anti-inflammatory agent that first came out of a different ARC, meaning the HIV trials, that this drug actually also was able to reduce certain cytokines and chemokines to then change fibrosis in NASH patients. So I bring this out just to point out, not that I want you to take away that we should start new agents on your patients, but that these are being tested, and that they're being tested with vastly different targets, and sometimes we don't even know the targets. I don't know what the target is for vitamin E. We don't know how to dose it. So these are quite important topics. And I'm not telling you to start it. And this is meant to be also from the same paper, but I wanted to highlight this, that the space is deep and broad, and that there are FXR approaches, there are specific molecules that are either being agonized or being mimicked. There are analogs of GLP-1, and we've heard about this in the diabetes space, but there are people who are approaching this from a variety of different standpoints. So I just want to point out that there's going to be more information coming, hopefully, in the next 5 years. So what about kids? I'm going to harken back to what Dr. Voss mentioned with cardiovascular risk. And I think this is quite important. And I want you to point that there is a paper, this is now 8 years old, from the New England Journal, about obesity, cardiovascular risk, and premature death. And the bottom line is that the higher your BMI is in a quartile at a young age, the greater the chance of dying later on. And so basically, if your BMI is high at ages 5 or 10, you have an increased risk of premature death, and it's mostly due to cardiovascular risk. Okay? And the slide that I find helpful, or at least in my thinking with cardiovascular risk, is how do you get from fatty liver to kind of more fat deposition and atherosclerotic plaques in places that shouldn't have plaques? This is your risk for cardiovascular death. And it ends up being that if you can model this by looking at the thickness of the carotid arteries, a non-invasive test, to give you a hint as to how much is going on. And in fact, it ends up being that if you just do an analysis of whether or not you have NASH or not, or just simple steatosis, and I don't like that word simple, it really is steatosis. And as you can tell, and I'll show you on a future slide, having steatosis is not so simple. Versus controls, the thickness of your carotid arteries is greater the more fat and the more liver disease progression you have. And the hard part is that this doesn't hurt. And So nobody knows this is happening, but it's happening. And the earlier this starts, it's not rocket science, the earlier this starts. And in fact, this has been shown in a recent paper from a French group, and I'll read out the title to you. Fatty liver is an independent predictor of early carotid atherosclerosis. In fact, the y-axis of this is plaque-free survival, meaning how much survival do you have without a plaque. And this is years of knowing whether you do or you don't have steatosis. And if you have steatosis at baseline, by 5 to 10 years later, you have less of a chance to be alive if you have plaque. So their bottom line is steatosis at baseline predicted carotid artery plaque occurrence. I would take this one step further back in time, that pediatric NAFLD is actually steatosis at baseline. So when I see patients like this in clinic, and it really comes with some zeal overseeing more and more of these kids over time, we are seeing this. And telling kids, though, this is okay, and have my adult colleagues take care of it is really not our goal. More than that, I want to point out a paper also came out 2 years ago that following patients' body mass index is a soft call, and we can have a discussion about this, but it is not a bad marker of perhaps liver fat. And there's probably the largest study that I know of where they followed Israeli army recruits. And the beautiful part about this is that it's both men and women, and it's supposedly, and it is, young, healthy people coming in, long period of time, 17 years of age, so afterwards. And they just said, what's your risk of cardiovascular disease later on? That's it. And I think the most sobering aspect of this, and you can see the different colors, if your BMI is more than 95th percentile early on, well, that's not rocket science, right? You're going to have increased mortality pretty soon, starting 20 or 30 years of follow-up. But what wasn't known is that if your BMI percentile was even something that I think, just as Dr. Voss mentioned, and with her case report, someone we wouldn't blink at in clinic, it's just a normal kid, their cardiovascular mortality risk later on in life is higher than those who weren't. So in other words, if you're above the 50th percentile average, you still have a high cardiovascular risk. So when we see kids who are definitely above that risk early in life and maybe have some other comorbidities, this is a concern. So I think that the problem here is not that they're going to die of liver disease primarily, they're going to die of cardiovascular death before they should. And our great advances in vaccination and public health and sanitation are going to be not necessarily erased, but they're going to be abrogated in a way that we don't want to see. So I'm going to skip this, but I'll go quickly. But bottom line here is that if you're overweight in late adolescence, you actually can get liver disease later on. And this is a Swedish study. You can tell it's a Swedish study because the percent of patients with a BMI greater than 25 is a lot less than those less than 25 at the beginning. But after 20 or 30 years here, you can see that just being overweight gives you the chance of severe liver disease later on. Okay? So just a BMI over 25 is a risk factor. And for the last slide or two, I want to bring together what Dr. Voss has shown with sugar intake and perhaps as a genetic contribution. And I think there is a genetic contribution as well as our own diet. And they seem like vague issues, but there are actually people who have said this is not so vague. We do need to know this. And that same PNPLA3 gene that Dr. Voss mentioned, that same genotype is present in 25% of Hispanic Americans. So it is not a small percentage. Very high. And in fact, what's shown here is that your fat fraction, if you're normal, is really not different if you take more sugar in. So this is a study saying, does your fat intake change based on how much sugar you take in and also your genotype for this one gene? Nor is it if you're heterozygous, but if you're homozygous for this, the more sugar you take in, the more fat you have. So there really is this nice correlation of genes plus diet. And it's not just this one slice of the population. It absolutely is both. And what I can't get into is that there probably is some imprinting changes that goes on in the way our liver is now deciding how it's going to handle its new caloric loads from the gut, that it may just be sugar, but it's everything else as well. Okay? So to summarize this, and there are some of these things in the summary that I gave short shrift to, but there is a role for bile acid biology and knowledge in NAFLD and NASH. I just highlighted it, but there are studies ongoing. There are complex roles for whether we should or shouldn't agonize or antagonize FXR. There are studies for that, when we have shown this in mice and published it, that if we block the uptake of bile acids in the intestine with a non-absorbable drug that blocks the uptake protein, this ASBT, we can change fatty liver in mice at least, but also there's a human study going on. The current therapeutic landscape, thankfully, is crowded as opposed to absent. And so we can go across with antifibrotics, a variety of different approaches, metabolic changes. But the likely story is this is not a one gene, one variant, one aspect target. It can't be. If it were, people would have figured this out. So there is a likely need for multiple approaches here to different aspects, whether you want to change the way the gut handles food or the way the liver handles fat. It's likely that we're going to need more than one. And so this is going to require cooperation and strong research. I think that to finalize what we're talking about here on the webinar is that the disease processes, they all start early and they actually persist. It's something that is starting, and it's really good that we bring this point out, not just to our families. The families are really lovingly open to change, and it's really a family story, and it works, and they don't want to have a problem in a shorter lifespan for their kids. But I think that that's really the concern, and that's what I see with every single child, that there's a future metabolic compromise that I would like to address or start to address early on, and with type 2 diabetes and cardiovascular risk as the number one, in addition to all the liver disease that we mentioned. And I want to thank you, and I'm finished with my part. Great.
Thank you, Dr. Karpin. Now I'd like to turn our webinar over to Jonathan Martin, who's going to moderate our question and answer period.
Thanks, Tom. Thank you, Drs. Karpin and Dr. Voss. It was very informative. We have a couple of questions that have come in, and feel free to post any additional questions that you have. I have a couple of folks in the room here monitoring the question box, so they'll grab my attention too if any other questions come in. I think the first question, I believe, is for, I guess, Dr. Voss, regarding your slide when you were looking at the obesity in preschoolers. Was there anything, you said that the highest rate of fatty liver in preschoolers was indicated by the dark blue boxes, and the question involves whether or not these clusters was there anything that attributed those clusters to any specific factors such as demographics or socioeconomic class, or was that information not available?
So that's a good question. So that's county level data, and while we have information on patient behaviors that are associated with obesity from other studies, from the county level, it's going to be more economic information. So lower economic, socioeconomic status communities do have higher rates of obesity, which is really shown by other studies. I think that really the point of that particular paper was to show how pervasive the high rate of obesity in preschoolers is across the country.
Thank you. There was a question that looks like it is about the limitations of enrolling for clinical trials of so many of the clinical trials around the liver involving the requirement for a biopsy. So are the clinical trials taking into consideration the concerns of parents and their children in using of biopsies? And do the trials allow for using any of the other imaging or studies, such as FibroScan, MRI, or CT?
I'll take the first crack, but I'm also going to ask Dr. Voss to weigh in because she wrestles with this a lot. Is that the answer is unfortunately yes and no for the reasons that you bring up, is that we don't have that. So there's more to it than just whether or not one does or doesn't need a biopsy. Miriam, would you like to comment on that?
Yeah, it's a really good question. So in my experience, patients and families are willing to get liver biopsies, and we certainly have improved our methodologies over the years. And so here at Children's, it's kind of a quick in and out procedure. They're in and out in 3 or 4 hours, and they can go to school the next day. It's not a overnight stay or anything like that. And we've also reduced the risk of bleeding through our interventional radiologists are able to do a gel foam plug. And I think those factors are very important. So this is different than 10 or 15 years ago, how liver biopsies were done in children. So I think that has helped. But then also, I really see that our patients and the parents of our patients understand the importance of this problem. And they are also very driven to find a cure, to find a solution for their child. And if the biopsy information is important for for their child's health, then the risk is worth it. Now, just getting a biopsy for without important information for that child's health is a different scenario. So I think we have to really weigh it patient by patient.
Okay, thank you. So I have a new question. How can the differences in histology in the pediatric population be taken into account for clinical trials in terms of pathological grading? Will there be any difference in the grading system for pediatrics?
That's another really good question. So right now, the NAS score, the NAFLD activity score, is often used in the United States in the clinical trials for the histology. And it doesn't capture portal inflammation, which, as we talked about, is important in the pediatric biopsies. And so I think that in the designing of pediatric trials, it is important to make sure that we capture the histologic features that are important to children. And so that's absolutely a consideration. Right now, we don't have kind of a score that represents the pediatric pathology well, but the components that are important are assessed by the pathologist and can be compared.
I would just chime in a bit that we're really working on meaning within the NASH CRN, and many other people are working on to try to find a validated surrogate marker for the biopsies, so that people really do believe for a long-term disease like this that there is value to some of the MRI measurements or some of the other serum biochemistry. So that's the issue I think that we're bringing up, is that we want to change these kids' trajectory, and the timelines for biopsies is really pretty short, even if it's 2 years later, to really come up with an answer. And so we have to decide whether or not there is really a value to knowing that, guess what, this intervention does change liver fat. This intervention does change some degrees of small molecule accumulations within the liver that we can measure. I think that's going to be the greatest benefit to continuing the biopsy component, is that you have to have trials where you do more than one thing, so you can answer those questions that then for the future trials, we don't need it. Right now, we're obligated based on this country's acceptance of what's a validated endpoint for NASH to do biopsy. It's hard.
Okay, in the interest of time, I'm going to move on to the last few slides here, where we'll talk about some of the resources that we offer. If you do have any last-minute questions, if they do come in and we still have time at the end, we will go ahead and come back to those questions. But for now, I'm going to go ahead and move on to this final section. The American Liver Foundation offers a variety of programming, including community education programs delivered by trained health educators. We sponsor throughout the year and around the country a variety of symposia, conferences, and Ask the Experts throughout our 16 staff divisions. We advocate to support public health research and education funding for NAFLD and NASH, including increased funding for the NIH. We are supporting the first International NASH Day, which is coming up on June 12th of next month. And we participate in community events and roundtables around the country. Another resource is our website. We offer myriad resources for you, the physicians, for your patients, and for their caregivers. And you can visit us at liverfoundation.org. And in the upper right-hand corner, there's a tab that says Healthcare Professionals that can provide, serve as a gateway into our resources for you and your patients. In particular, on our website, there are a couple of specific resources which our visitors find helpful. We have a clinical trial locator, which is powered by a company called Antidote. It provides clinical trial information that aggregates from clinicaltrials.gov to help patients find trials for which they may be eligible. It's a great resource in that it takes the inclusion and exclusion criteria available through clinicaltrials.gov and walks the user through a series of questions that helps filter out the trials for which they're ineligible based on simple criteria available on the clinical trials website. And then it returns a list of trials that meet possibly meets their eligibility. We also partnered with a company called Amino to provide a physician locator. This tool uses algorithms powered by claims data to help patients identify a specialist who has the most experience treating people with a specific condition. It allows people to identify physicians in their area or within a range, a certain distance, and helps them find someone who may be a particular help to them. ALF doesn't specifically provide referrals, but we do refer people to this tool so they can identify physicians that they may want to poll or interview. We have printed resources available, in particular, a variety of resources specifically online and in print in a variety of languages. You can contact our helpline if you'd like to request printed copies of these for your office, but they are all printable from our website as PDFs as well. Our helpline, oops. Okay, so our helpline, 800-GO-LIVER, or 800-465-4837, has trained helpline specialists that can help you with your patients with questions about liver health and wellness, as well as help in living well with liver disease. The helpline uses a translation service, so if someone needs to speak with one of our representatives in a language other than English, we can get connected through a service that provides translation in hundreds of different languages and dialects. So English is not required to be able to be served by our helpline. I'll just check in here quickly with Megan. It looks like we do have a couple more questions, and we have another minute or so, so let's go ahead and get to one of these questions. Okay, so what percentage change in MRI PDFF correlates with histology? Do you need to hit 30% relative reduction?
Oh, that's a good question. So the percentage change will depend on where they started. So you can look at that slide where it shows the percentage of fat in the liver and the level is, how it's associated with the grades of steatosis. Right now, steatosis is graded on biopsy by less than 5% is not NAFLD, and 5 to 33%, and then 33 to 66%, 66 and greater. And so that was always how it was graded when we had biopsies. But now that we have MRI, we have these very, very accurate percentages, and how much of those are clinically relevant or how much needs to happen in order to say that it's an important change, I think that really remains to be seen.
Okay, that's all we have time for today. There were just a couple of questions that we are not going to get to, but we will respond back to you individually with those questions. We'll pose them to our speakers by email and see if there's a way they can answer those questions for you privately. I'd like to thank everyone again for participating, in particular Dr. Voss and Dr. Karpin, who are joining us today from Emory University in Atlanta. Our president and CEO, Tom Nealon, whose office is based in Miami, but is with the physicians in Atlanta today. Also, I'd like to thank Cynthia and Megan here in our New York office with me for helping to monitor the questions. And thank you all for participating. The webinar will be available as a recording on our website. We will send a link out to all of the participants by email. And in closing, we'd like to thank Gemfire Therapeutics for your support of today's program, and request that everyone participating please fill out the evaluation that will appear on your screen as soon as the webinar is completed. Thank you all and have a great day.